Hello.
Yes.
Hello.
Hold on
This
just.
is Belinda. This is Belinda from Benchmark as well. In addition to those questions, I'd like to ask what is his Axis 3 diagnosis? What is it? What is his medical issues as well?
Okay, he has multiple. He had a pneumonia, which is cleared now. He was treated with IV antibiotics, and they switched it to PO, and he has completed that. Then he has anemia too. His blood count has improved after he had the blood transfusion, so he needs to be monitored by a primary care physician. And he also has seizure disorder, for which he's on Depakote. But he hasn't had any recent seizures. So, does that answer the question?
Some of it. Now, I understand that he had a J-tube until very recently. So how is his intake? Is his weight stable?
And the J-tube? He does. Yeah, he doesn't have that now. Does he have a tube? He doesn't have a tube.
For how long?
Pure. Okay. Well, he eats liquid food. Pureed food.
He had an aspiration.
Yeah. That's where the pneumonia came from. He had an aspiration. But that's since cleared. So he can tolerate, liquefied food.
Right, and that was an issue with him when he was living at the crisis home before, is he had continued aspirations and had to have the tube placed. And it sounds like he's still having some aspiration issues.
Nothing at Laurelwood. And secondly, that's something that medical doctors, they can do a swallow studies on him to see whether they can do any specific recommendation for that.
Right, well, all of that was done prior, and it was my understanding that his level of care needs to change to a nursing home, a skilled level of care. And so what I'm trying to ascertain is, does he still meet the criteria for a skilled level of care, which would be facility-based? And
that's beyond my scope. I don't do the assessment of that.
Right. We can comment on how he's done here at Laurelwood, and he's been swallowing his medications.
He's swallowing his medication and eating. We haven't had any concern about aspiration while he's been here.
So we can't comment on what's happened in the past. We're really focused on how he's done here at Laurelwood, and the fact that at this point our team is coming together to look at with you all what's the next placement for Joseph. And Ms. Hawkins, did you make it to the call?
Yes.
Okay, Ms. Hawkins, this is Adam with Laurelwood, and there are lots and lots of folks on the call. I'm going to run through a list of everybody that's on the call. Would that be helpful for you, Ms. Hawkins?
Yes, ma'am. Yes, sir.
That's okay. I've been called worse. So we've got Mr. Charles Fettner with the Region 1 office, and we've got Marion Gordon with the Region 1 office. We've got Jerry Speed with Georgia Advocacy. We've got Michael Free with Lookout Mountain. We've got Belinda Christensen, Michael Freck, and Joe Darling with Benchmark. And then Tika here at Laurelwood. And we've got Dennis Frady at Laurelwood, Dr. Acosta, Vicki Bishop, myself, Nancy Brooks. So we have lots of folks from the medical center as well on this call.
Okay.
And so Dr. Acosta has been updating everyone on how Joseph has done here at Laurelwood. And so they had some questions, and we're just answering those now, okay?
Okay, thank you.
The previous question, can you clarify the question again?
Adam, this is Belinda. I guess essentially what I'm asking is, why is discharge back to the nursing home he came from? Why is that not an option? And why that is, does he need another level of care, or can we take placement back there with maybe some in-home supports to help them manage him?
Okay, well, I'll let Henry speak to his concerns about that. Henry's on the call.
Yes, this is Henry Robertson, the administrator of New Horizons Limestone. Our biggest concern has been behavioral. This is a skilled nursing facility with a lot of elderly, many with varying degrees of dementia. Our residents, as he got more comfortable with the building, he was going around in his wheelchair all over the building. He was going into residence rooms who were very compromised and very defenseless. He struck, I'm aware of him having struck 5 residents and 2 staff members, and even equally concerning, he seemed to develop an attraction to tubes, and was found frequently in a resident's room that is on a trach on oxygen, and our nurses had to sort of rescue that resident from JoJo. We cannot, in our setting, we are not to chemically or residents, and with his capability of him, he should be allowed to go around, but he doesn't have the capacity to know that he can't do inappropriate things with our residents. And unfortunately also, our residents, again, with various levels of dementia or whatever's going on with them, sometimes they don't respond to residents like JoJo ideally. And so we've had multiple altercations. And I don't feel like, at least in my facility, I have to be thinking of the welfare of my other residents, and it was not working.
Okay, did he exhibit that behavior the entire time he's been there, or is that something that recently started? Because I understand that he's psychiatrically stable now, so those behaviors should not be occurring.
No, those behaviors were increasing. Soon after he got to us, we did not have that. As I was told, I was not aware, or the incidences were very, very few, or they didn't start until after he'd been here a while. Then they seemed to get worse, and I do think he was getting more comfortable in the area and going around and visiting all over the place, and that was creating more problems.
I think from our perspective, one thing we like to look at is the least restrictive environment for the patients. And, he's done really well. We have an open milieu system here. He does wander over and he starts to grab, other patients' drinks and things like that. And depending on the other patient, that could escalate to an altercation because, they don't want somebody else drinking their beverage. And so we haven't had that here, but I can see what Henry's referring to, because if he's just wandering into other patients' rooms, I can see where that would create some opportunity for some negative interactions. I'd like to ask Ms. Hawkins, from your perspective, where has Joseph done the best in the past? Where has he done well, in your opinion?
Well, I think when he was in Southern Haven at Dalton in the personal care home for over a year, he done really well, and he done really, really good at Horizon when it was open in Fort Oglethorpe.
Okay.
He likes to be where he can go in and out, and they let him go in and out, and he played basketball and took garbage out and everything when he was in Southern Haven, and they let him go out, and they'd stand and watch him, and he'd go out and talk and interact with other people that was walking the walking track up at Fort Oglethorpe at Horizon. So he kind of likes to be free, and he don't understand the patients that...
Where's Ray?
Huh?
I'm sorry?
He don't understand now the patients are not able to respond to him. And a lot of the people that's worked with Joe in the last 2 or 3 years has sort of catered to Joe, and sort of anything he wanted, they tried to do for him. If he wanted a Coke or whatever he wanted.
Right. He's a very charming individual, and I can see where that would happen, Ms. Hawkins. And I think that's probably why he's done so well here, is because we have an open milieu, and so he's able to walk around, and even though we're a lockdown facility, within the unit, he's able, as long as he's not agitating other patients or doing things like that, he's able to walk freely on the unit. He can go into his room, he can come out in groups, he has the opportunity just to roam freely, as you say. And I think some of these other environments that he's been in, fortunately, they just aren't, that's not the way they're set up. And I think that has created some of that increased behavior that Henry was referring to. The more comfortable he felt in the facility, the more willing he was to kind of roam around, but that creates some risk for himself and for other patients as well.
Isn't he in a wheelchair now?
No, he has been in a wheelchair here at Laurelwood. He's able to ambulate. He's never been in a wheelchair here.
Okay, does he have steady gait?
His gait, I mean, his gait's pretty steady. I think if he has to have medication, which I don't think has happened very, very often here, and he's not had any falls, so I think his gait is fine. You know, falls. Yes, sir.
Adam, this is Charles Fettner, Ms. Hawkins. We have a temporary or a place for a temporary stay available, but it's licensed as a personal care home. It's the respite home that he was in before he went into the medical center last October. But before he could be admitted there, we would need somebody from the medical floor to say that he is medically stable enough and can function, or that that level of care can meet his needs. Jamie, do you think the physician that followed him earlier could...
Mr. Fettner?
Yes.
He can't, Charles, because he's not in the medical center anymore, so he doesn't, his doctors are at Laurelwood, so Dr. Costa would have to make that decision.
Right. Jamie, we've got Vicki here, Mr. Fettner. She's going to answer your question.
Okay.
One of our sort of requirements at Laurelwood is that a patient, if they have been at the medical center, they have been deemed medically cleared in order to be a patient here at Laurelwood. So we consider him now medically stable.
But look at his history. He was in a intensive care unit, went to a skilled nursing facility, was in a psychiatric hospital, and the option that we have available is, in essence, a residential personal care home with no medical oversight.
I think, if I may speak, I think part of him going to the skilled nursing facility was it was the best option we had on the table. In actuality, we escalated some of his behaviors that led to a psychiatric admission, in my opinion, by putting him in that facility, if that makes sense, because it was less restrictive than the medical floor on our hospital unit, but it's not the least restrictive environment that I think would be beneficial to Joe. And so we kind of created an atmosphere where we may have triggered some of that behavior that led to a psychiatric admission. That's my opinion. Just looking at the case and reviewing his history, and honestly, Laurelwood's not the place for him. I don't believe the skilled nursing facility is the best place for him.
Adam, this is Belinda again. Now, when he was with us at the crisis home, we saw a significant decline in his level of functioning. Walking, he went from walking, talking, to falling, frequent falls, to not eating, having to be fed, and ended up in inpatient medical facility for several months. And so my concern is, what level of care does he need for support? Because, I sort of agreed at the time he needed skilled nursing level of care. And I think what my question is what has changed that he doesn't need skilled level of care anymore? Is he able to be supported in a community, in a residential home that doesn't have 24/7 nursing available?
Well, I want to add that when he was in the crisis home, it took 2 or 3 trips to the emergency room to get him the care that he needed that we weren't able to deliver.
Well, I guess the question would be, was his psychiatric condition deteriorating to the point that we started seeing some medical issues? And I know that he ended up on our medical floor. But as Dr. Acosta has said, he seems to have responded positively to the two
antibiotics. He felt like maybe the anemia and the recent pneumonia maybe was put him down medically, and now he's better.
Right.
He's now cleared.
And I know historically, I mean, as you said, Mr. Fedner, if you look at his past, and I understand the concerns, and we can definitely look at that as we look at, you know, the next step for him. But currently, he's not meeting any criteria to remain here at Laurelwood, and I think we need to look at what's currently going on with him and give him an opportunity to do well in the least restrictive environment. And he may need another acute intervention if we do that. But I think it's not really, to me, it's not really fair to the patient, to Joseph, if we plan his next step based on everything that's happened in the past and not really what's currently going on. That's just, again, that's my opinion.
And Adam, I totally agree with you. I just want to make sure that we don't put him in a situation that's not capable to meet his medical needs.
I agree, and I think that, you know, us establishing a primary care physician, and maybe that he needs to see a PCP more frequently to make sure that medically he's doing okay, as well as his psychiatric needs. It sounds like psychiatrically he's stabilized, and Dr. Acosta feels like we're at baseline. But I do think that, you know, as long as he has his psychiatric appointments that are pretty routine, and medically we're checking him out, in an environment where folks have some training and some expertise in how to manage, you know, adults with developmental disabilities, that's going to be key, because he's going to continue to wander and, you know, get into things that aren't his. I mean, I think that's just part of who Joseph is. And Ms. Hawkins, you can speak to that more than I can. I just met him, really. I'm just getting to know him.
Well, let me just, and this is Michael Free, and let me just add that he was at our facility, which was a licensed personal care home at Horizons in Fort Oglethorpe for over a year. And for the majority of the time that he was there, he required one-on-one supervision to keep him from getting into potentially dangerous situations. It was not a locked facility, so if he went outside, he had to have one-on-one escort everywhere he went. You know, it is a very staff-intensive need there that Joe has, which for some time, and when Joe is doing well physically, as it appears he probably is now, he will require that. He'll be more ambulatory. He will be able to get around. He'll need to be constantly redirected to keep him from, you know, doing things that could become confrontational with other residents, or just to protect him. So.
You're right, and I don't think that's ever going to change because of his cognitive functioning. I mean,
I agree.
That is who Joseph is, and we all know that.
Ms. Hawkins.
I'd like to
Yes.
interject here for
Ms. Hawkins,
Jerry Speed.
Yes.
And this is Jerry, and consistently since Joe was at Northwest when the hospital closed, the recommendation from folks has consistently been that Joe does best in a small environment with 24/7 awake supervision and the supports that he needs for his ADLs. And a quiet environment. The seizures are often triggered by noise and light, and it sounds like a personal care home with the proper supports and would be the ideal situation for him. The key, as everybody I think is bringing to light, is making sure that he has the supervision that he needs, and how we can make that happen so that in the personal care home he has that extra support.
Ms. Hawkins,
Yes, sir.
do you recall the respite home that he was in last fall over in Gainesville?
Not right off, I don't.
The Benchmark Crisis Home?
Was that what it was?
Yes, ma'am. Would you be agreeable for him to go to that home for a temporary period while we develop something more long-term, assuming that Benchmark staff feel that they can meet his needs?
Well, that's where he fell sick, and I'm just going to be up front with you as his mother. I have kept close contact with Joe, and I have been told so many different stories in different ways by different people. And I have asked about his medication, and I've been told quite a few different stories by different people about his medication. I was told different stories in the nursing home. Yes, he's doing okay, he's walking. Yes, he's in a wheelchair. No, he's not on this. And yes, he's on that. I mean, you know, for me, I just like to get the bottom of everything with Joe and his care. Because we both live in such uncertainty all the time with his illness. And he just needs to be where he can be free and somebody just watch him. And I mean, if he was in like a fenced-in yard, you know, where he could just go in and out, you wouldn't have to worry about him, you know, running off. I think that would work just fine until he got adjusted to a place. Because like I said, now he played basketball, he went everywhere at Southern Haven in Dalton at that personal care home. It all depends on the training of the person to handle Joe and who the person is.
Our goal is to get him into a community home closer to where he lives, back in the Lookout Mountain community.
Yes, sir.
But we don't have that available immediately. So if his care can be met in that respite home in Gainesville,
the same one.
While Michael Free and Lookout Mountain develop that home and get it staffed, that would be our goal.
So
I just wanted you to know, I wanted your agreement of taking this approach.
Well, could you give me kind of a time period when all that will happen?
Let's get him into the respite home and get a good assessment of what he would need, and then we can give you a better estimate of how long it's going to take to arrange it and prepare it.
So he'll go back to the respite home that he was in when he left Horizon up here?
Yes, ma'am.
Do you think they'll be able to meet his needs there?
Well, we're going to...
I mean, I'm not talking about
We're going to have people assess him and determine that, and if they feel they can meet his needs, yes, ma'am. I'd have confidence that they wouldn't take him in if they didn't feel they could take care of him.
Okay, I know with the patient or with the client or with the person with the mental illness like Joe has, you're always living in uncertainty, and you keep trying and trying to find the best of care for them.
Yes, ma'am, I understand that.
And you keep trying to get him, because Joe does a lot better, and he does real well when he can be to where his mother and his family can visit him.
Okay. Now, let me ask Adam and Belinda, what can we do to have a physician examine him and say that whether he can or cannot go to a residential setting without 24/7 nursing care? And then Belinda, what would it take for you and your staff to feel comfortable to go ahead and move him into the home? How can we arrange those two steps to be coordinated and good communication?
Charles, this is Belinda. I would be happy to come and do a nursing assessment on him, and that would be our first step in deciding the support. My biggest concern is moving his level of care. So I would definitely need a physician to give us some guidance because his DMA-6 in level 1 and level 2 says he needs skilled nursing care.
I understand, and I agree with you.
7. And we don't have that at the crisis home.
Right.
You know, I have an LPN house manager, but there's definitely not 24/7 nursing. So I would need some documentation that he's improved and he needs a nurse X amount of hours or what his supports are since they're changing.
Okay, Adam and Jamie, can y'all help in this regard?
Belinda?
Let Vicky answer some of Belinda's questions.
Yes, this is Vicki. I'm a nurse, and I would think that would be a good idea. You could actually come here and meet with our nurse practitioner, Nancy, who would go in with you. And you could do an assessment and do a nursing assessment, or if Nancy is not here, I could do that, or one of the nurses on the floor could go with you and answer any questions you might have.
Okay, that would be great.
From a nursing perspective, we could certainly do that.
I think Dr. Acosta, who's a medical doctor, could give you the information that you need, that you requested.
So when can we make all this happen?
Yes, we can make all that happen.
I say, but when?
I mean, whenever Belinda's ready.
Okay.
Okay, I'm looking at my schedule. Let's see, I could come tomorrow, pretty tied up Thursday and Friday, or the 14th.
Tomorrow works for us.
Okay.
You just tell us what time. We're here.
All right, well, I have to get my map clicked out and see how far away I am. I'm in Milledgeville, so I know I'm probably between 2 and 3 hours away from
Yeah.
Milledgeville.
Milledgeville to Gainesville, you're looking at 3 hours.
Yeah. So maybe early afternoon, around 1:30.
Great. Sounds great.
Joe Darling, the regional director, once he gets to should he make it to the Gainesville crisis home, our history with him is we had no problem managing him for a while, but when he starts becoming medically unstable, that's not our expertise.
Well, I think
I'm afraid of being in that position again because his history over the past couple of years shows that will happen very quickly. And so, pretty much, I guess my
I think, this is Vicki again, I think, trying to look ahead on things like that, obviously, I think just because of just his past history, we are going to see that at some point, and I just think, from our perspective, we always give a 7-day first appointment, both, we try to do a primary care, we try to do a psychiatric appointment within 7 days, and I think that right there would be our first step in making sure that somebody is going to see him on both disciplines and making sure that both of those disciplines are in concert with one another, making sure that they talk to each other frequently about him and hopefully keep him out of the hospital setting as much as possible.
I would hope that would happen. The experience we had last year that Joe's talking about is we were seeing a significant decline in his health status, and we were taking him to a doctor, and the doctor was admitting him to the hospital for tests, and then they were discharging him the next day, and I was getting all kind of blessed out from the hospital staff saying, I don't know why it's here, and y'all need to come get him, and y'all are not taking care of him. We had really bad experiences getting someone to understand that there was something going on with him, that he had an illness. And, we want to keep Joe safe, and we want to make sure that he gets the attention that he needs.
Well, I really hate that you had that experience, and there's nothing I can do about it. At this point, the Laurelwood folks are involved, and I'm involved specifically. And so I think for Joe's best interest, then we can work through some of the barriers you may have experienced in the past. I feel like with all the resources we have at the
earlier, prior to Joe decompensating medically, the process was ongoing. He was just supposed to be at a crisis home temporarily so that they could set up the supports back closer to his mom. And so that process was going on. Medical process came up, and we had lots of meetings with lots of people, and here we are months later, and we're like starting from scratch again. And that doesn't help Joe in.
I understand, Joe, and Lookout Mountain is committed to pursuing a personal care home with adequate staffing. What happened last time, though, was that it looked as though his medical needs were greater than you would normally provide in a personal care home. And at this point, it sounds like we're not going to have to experience that. It'll be a more typical staffing of a mental health primary focus, with obviously still addressing his medical needs, but not to the extent of last fall. But we would approach this as a temporary and hopefully a much briefer stay there than last year. Michael,
Yeah.
You agree?
I do agree. I think the key ingredient here is that Joe stay as healthy as he can, because once he starts, this problem with pneumonia and aspiration has been an ongoing issue, and hopefully we can get that better managed. And
Has he had a nutritional assessment?
I think he's had just about every assessment he could have had when he was at Northeast.
Right, and he had swallowing studies when he was at the crisis home last fall.
Mm-hmm.
Right. We have to bear in mind, this is an adult, but this is an adult who's very young, and so, I think to say we cured him of all his medical issues, I don't think any of us can answer that question, but I think he deserves a shot to live and give, and we're going to do everything we can to support Benchmark and Lookout Mountain. I think we're all in agreement that we want to do everything we can to support him, and nutritional assessment, we can do everything we can do. I can tell you currently here, we've just not seen any of the issues, and that's not to say they're not going to come up again. It's just we haven't experienced those here, and he's not required a lot out of us. So, and maybe that's just because he feels comfortable in our environment, or our staff know how to interact with him in a way that doesn't agitate him. I think that's part of it. He feels comfortable and safe here.
And I have no doubt at the crisis home, if he's, anything behaviorally, anything psychiatrically, we're fully equipped to handle that. And we can pick up on medical indices that his health is deteriorating, but we're not equipped to jump on it quickly. And again, going back to our previous history, we had trouble getting doctors to listen to us that he was not doing well.
We will commit to, and Vicki, our case manager, she has a part in this as well, we will commit to making sure he's got scheduled appointments with the PCP before he leaves. That'll be part of the coordination with your staff, Joe, is to make sure he has those appointments in place so that there's no gap in service as far as his medical and his psychiatric treatment.
Would his ongoing psychiatric care be something that's available through Laurelwood, or do we need to maybe set that up through Avita in Gainesville?
Avita in Gainesville would be my first guess, and we know those folks well, and I know the directors over there, and so whatever we can do to help with that, we will do. We have a good working relationship with Avita.
If you'll make that contact, and you'll be arranging for a primary care physician as well.
Okay.
And they'll be, assuming Belinda's comfortable that they can meet his care, his needs, then
we still need a doctor to say that he no longer needs a skilled nursing level of care.
Okay, that'll be taken care of, and tomorrow Belinda will do her assessment, and we'll have a better idea from her what we're looking at, and we can go ahead and make the arrangements.
And assuming Belinda's comfortable, the doctor is okay to discharge him, when would you have the capability to actually move him to the crisis home, Joe?
As soon as the medical appointments are in place. So if Belinda is comfortable with him coming, and we've got follow-up medical appointments, frequent follow-up medical appointments, to make sure we have an extra set of eyes on him, we're good to go.
Are you saying you would actually want him to go to the primary care physician, or just have a follow-up appointment?
Have a follow-up appointment. If Belinda is comfortable, definitely have follow-up appointments with PCP and psychiatry set up, and to have those continue on a regular basis.
Okay. So conceivably, you're prepared to accept him this Friday?
Conceivably.
Well, Belinda, it's up to you and Joe and your comfort level. And, I think Adam is very amenable to work with us. If you need whatever supports you think is needed, work through him. And, we want to make sure his needs are met. There are contingency plans in the event he deteriorates unexpectedly. So, Adam, I guess at this point, I'm asking you to take the lead on all this and coordinate all the parties.
Right.
And if we run into a roadblock, you'll schedule another conference call?
Yes, sir.
I'd also like to add to make sure that there is a plan already started for him to move back home, so that he can get to where he's going to stay for a while.
Michael?
Well, we will start that process, right away to develop. We do not have anything in place today. We will have to start that search, but we will do everything we can to make that happen as fast as possible.
Joe, I'm working with Michael. We've got funding already available, so it's just a matter of hiring the staff and renting a space.
I don't have a problem taking the lead, and if we run into any barriers, I can pull us all back together and go from there. Ms. Hawkins, everything sounding okay to you?
Yes, sir. So far, everything sounds pretty reasonable, because my main concern is getting him back close to the family, because he seems to do so much better, especially since I've always been there for Joe all his life.
Yes, ma'am.
And I'm still here for Joe.
All righty.
Jerry Speed, I was asking you, are you okay with this approach?
Yes, I certainly am.
Okay. Adam, thank you.
No, thank you.
If anything I can do to help you, let me know.
I will do it. I appreciate everyone taking time out of their schedule to join the call, and I think that we can come up with a good plan for Joseph, and we can help him be successful.
Thank you, everybody.
Thank you.
Thank you.
Bye-bye.
Bye-bye.